Welcome to Community Health Matters. I'm your host, Kristen Presall. Both men and women may experience incontinence, the lack of bladder or bowel control, and the worries and embarrassment that come with it. Dr. Barry Jarnagin of the Cool Springs Incontinence Institute will discuss the causes, symptoms, and treatments of incontinence. More than 1.2 million Tennesseans suffer from arthritis. Arthritis and other forms of joint pain can reduce mobility and limit participation in daily activities. Dr. William Kurtz from Tennessee Orthopedic Alliance joins us to discuss joint pain and when it's appropriate to consider joint replacement surgery. As baby boomers continue to age, there's an increased need for Alzheimer's education and research. Andrew Sandler from Abe's Garden, an Alzheimer's and Memory Care Center of Excellence, joins us to talk about Alzheimer's and dementia. All that coming up next on Community Health Matters. Did you know, on average, women wait 6.5 years before talking to their doctor about their bladder control issues? Well, that's a long time to live with symptoms of incontinence. Women used to wait an average of 10 years before bringing up the problem to their doctor. The risk of incontinence increases as you age, but can begin as young as 20 and as late as 98 years of age. If you're experiencing symptoms of incontinence, don't be embarrassed and don't put off talking to your doctor. Hi everyone, thanks so much for tuning in. Today we're going to be talking with Dr. Barry Jarnagin, who specializes in urogynecology, and he actually has a partnership with the Cool Springs Incontinence Institute. That's what we're talking about today, is incontinence. And it is one of those things that probably not a lot of people want to talk about, Dr. Jarnagin, but if you can, for those folks who don't know what it is, tell us or define it for us, please.
Well, incontinence is simply losing urine or stool when you don't want to. So it's an accident. Okay. And the thing that really needs to be really strongly addressed is it's never normal. So even though it becomes more prominent as we get older, it is never normal. So if anybody has incontinence or an accidental leaking, then it is not normal and it needs to be addressed.
Sure. You know, I just had mentioned a lot of people don't really want to talk about those kind of things, and sometimes not even to their doctor. Am I saying that correctly? I mean, is that true?
Absolutely. It's something that nobody wants to talk about, and I've had people referred to me for the problem, and they'll get in my office knowing that I specialize in it, and they still don't want to talk about it. So out, you know, with other people and other providers, they hardly ever, it's very difficult for people to talk about.
How do you start the conversation, if you don't mind me asking? Because even people at home can kind of maybe for a loved one, get that conversation going as well?
Well, I think it's really a matter of relationship and looking them square in the eye. Sure. And having a conversation. And, you know, I started by asking why they're here in the office and trying to see if they'll tell me. And if they won't, then a lot of times they've written it on a pre-printed form or a pre-printed questionnaire, so I can look and then I can say, it looks like you're suffering from this problem, and you know, would you like to explain kind of how it bothers you? Okay, what causes incontinence? There's multiple causes, and that's one of the big things that people don't recognize. They think it's only, you know, it is a problem in and of itself. It's really a symptom of a much greater problem, and that problem can be anatomical, generally related to childbirth is the biggest cause, although other surgeries can cause that. Or it can be neurologic. There's many women who come in who have back disease or some other kind of problem, or it can be, again, related to childbirth where nerve injury occurred at childbirth. So it can be anatomical or it can be functional. And so that's part of what I try to do, is define and determine which of those it is so that we can best direct treatment in that direction. All right, when you're asking your patients, you know, what seems to be the issue today or why did you come here, obviously they're going to be talking about what's happening. But what kind of symptoms should somebody be looking out for at home to lead them to believe this might be me, I might be dealing with incontinence? So there's some basic symptoms that tend to occur, and one set of symptoms are related to laughing, sneezing, coughing, jumping on the trampoline with your kids, jogging, activity-related incontinence. Then there's a totally different type of incontinence that has nothing to do with activity, but is related to urge and urge-type incontinence, where they get the sensation they have to go, and then they just simply can't make it to the bathroom in time. That's the type that you're running the water, you're washing dishes, you're running the water, or something like that, or you hear water running, and all of a sudden it makes you kind of tighten up and try to make it to the bathroom and can't, or you're at the front door trying to unlock it and you just can't get it unlocked in time. But it's those kinds of things. It's spontaneous. It happens without any kind of warning and that sort of thing.
Okay, you had mentioned that obviously people who have this condition usually have maybe gone through some sort of surgical procedure, or have had a child, or had some sort of issue as far as, you know, a nerve issue. But as we age, is it something obviously that we should be aware of as well? Absolutely.
And people ask all the time, why didn't, if it's related to childbirth or if it's related to X, Y, or Z, why didn't it occur then? And it just takes time and as time goes on, that small injury that occurs at childbirth or at whatever, over time tends to get worse. And quite frankly, as we get older, our ability to compensate for those injuries that occur become less. And so the symptom may occur 20 years or so, give or take, after the event that actually caused it. And so they need to be looking for that leaking when they laugh, sneeze, cough, or that urge or that spontaneous leak that they can't control.
Absolutely. And when people experience this, Dr. Jarnagin, obviously they're going to want to know right from you the fastest remedy. What can I do? Is there medicine I can take? Is there a treatment option for me? Let's talk about going from simple to even surgery if possible.
So there's a few things that help no matter what type of incontinence you have. And that is pelvic floor exercises. And that can be as simple as people have heard of Kegels all their life, but yes, tightening down and trying to do that. Now, unfortunately, many women, by the time they get to my office, they lose that ability to do that. Their brain thinks they're doing it, but their body is not responding. And so those women, or more women, may want to get into formal physical therapy. And that's a good way to start, is trying to get the muscles rehabbed and regenerated. So to go from there, then there's behavioral things you can do. You can kind of put your body on a schedule, and sometimes that will offer value. Looking at your diet, seeing what things tend to cause issues. Sodas, carbonated beverages tend to get people to go more frequently. And so if you're drinking a lot of sodas and you cut back, that can make a big difference. Coffee is another thing that can stimulate. Teas can stimulate. So you can kind of look at what you're eating and drinking that may be contributing to the problem. So those are kind of the basic things that kind of help no matter what kind of problem you're having. The other thing, so then when you get beyond that, then it becomes more focused on what's causing the problem. And then you can go into, depending on the type, there are medications that may offer some value. If that doesn't work, then you can kind of move into what's called neuromodulation, which is where we actually try to get the communication between the brain and the bladder better. And that's where we get it. There's an office procedure that can be done that's kind of like 21st century acupuncture. And then there is a pacemaker type device that is an outpatient procedure that we do under sedation that can go in, and much like the pacemaker that's in the heart, that kind of regulates the nerve and the communication to make the heart that's beating too fast slow down and the heart that's beating too slow to speed up. The pacemaker for the bladder does a similar thing. It can regulate and modulate the ability to the bladder to contract effectively and relax effectively. And then there's Botox to the bladder. And women all know about Botox.
Yes, and for different reasons, obviously.
We're putting Botox everywhere now.
Yes.
And so we can now put Botox into the bladder, and that will tend to relax the bladder so that that urge, that spontaneous leak, is limited and doesn't occur. So that's kind of that side of it. And then the other side is, if you're looking at leaking when you laugh, sneeze, cough, and activity, there too is an office procedure that we can do. It's called bulking. It kind of tightens down on the urethra so that it gives the urethra a little help of resisting that urine from going by. And then there's the outpatient slings that can be done. And there's a lot of things that have occurred in the newspaper, et cetera, about slings, but slings really are overall pretty safe and actually really safe and fairly easy to do. And recovery time is very short. They can come in and have it done. And I've had school teachers have it done at the end of a week and be back teaching school by the middle of the next week. So, so it can be something that can be quite effective. There's also other surgeries that can be done to help lift and help with the incontinence of activity.
All right, terrific. So we know what can be what can be helpful if you have this issue that you're dealing with. Dr. Barry Jarnagin, thank you so much for your time today.
Absolutely. Thank you for having me.
Did you know children can get arthritis too? More than 300,000 American children and almost 6,000 Tennessee youth suffer from juvenile arthritis that causes joint pain and decreased mobility. There are 9 types of juvenile arthritis, which is used as an umbrella term for a number of childhood diseases that affect the joints. To learn more about the forms and symptoms of juvenile arthritis, talk to your child's doctor or visit the website kidsgetarthritis2.org. Hi everyone, we're visiting now with Dr. William Kurtz, who is the Chief of Orthopedics with St. Thomas Midtown, and he's also affiliated with Tennessee Orthopedic Alliance. We welcome you to the program.
Thank you for having me.
Yeah, thanks for visiting with us. We're talking about something that affects a lot of people, and depending on your age, of course, and maybe if you've had an accident or an issue, joint pain. A lot of people experience this. If you kind of can tell everyone what exactly joint pain is.
So most people with joint pain, we're talking today about arthritis predominantly. These are people that have been living with the pain for a while. Typically, they've been having symptoms for a couple months, and the symptoms tend to gradually escalate over time. The other side of the equation is the people who slip and fall on the ice like this week, and it's more serious and more acute issues. But the chronic issues, the joint pains, the arthritis pains, are what we're talking about today. It typically happens a lot of times in the knees and the hips are probably the most common, sometimes the shoulders as well. But you can get arthritis in any joint. And a lot of times it's due to previous injuries or overuse, or sometimes weight can play an issue in that as well.
Okay, if my mom suffered from some sort of arthritic problem, does that mean my chances are greater because, I mean, are we talking genetic disposition?
Yeah.
Sure.
You know, a little bit more for the hips than for the knees. Most of the time, I mean, the common line is that your genetics kind of make you predisposed to maybe getting a problem, but then some of the things that happen to us throughout our lives, whether it's an injury or a trauma of some kind of tips you over the edge. So the underlying story is that your genetics may kind of load the gun, but your environment may pull the trigger and make you ultimately have knee arthritis or hip arthritis.
At what point do you go to see your doctor to maybe complain about this? Because some people deal with it regardless, and they're like, I'm tough, I can handle it. Yeah. But when should you pick up the phone?
It's when your symptoms get to be interfering with your daily activities, when it really is impacting your life. You know, most people will kind of start off with just some simple home remedies with Aleve or ibuprofens or Motrins and those sort of things, the anti-inflammatories. They'll start with those initially, and that's fine as long as your kidneys are working fine and you don't have any other major medical issues. And so people will start with that, and that can usually buy people some time, maybe a year or two with some relief. And then they'll start trickling into the office with pain that says they're not getting enough comfort from the anti-inflammatories. And oftentimes we can do some non-operative remedies, some shots and some other medications and other things to kind of help them through the process, and maybe buy them a couple more years of time before ultimately the end decision is when to do surgery, which is oftentimes a joint replacement.
And obviously an office visit is going to determine the type of treatment any patient requires. So how do you determine that? I mean, at what point does somebody have to, what's their condition for them to have to go have surgery as opposed to just be treated with medicine? Sure.
So I usually see people for 2 or 3 years before I end up operating on them. So there's a long time there just with non-operative treatment in a lot of situations. And my job is to try to buy people some time and maybe let them live a healthy, productive life, hopefully pain-free, for a while before their arthritis gets to be so severe that the non-operative treatment just doesn't work. And for everybody, it's a little bit different. Some people are a little bit more timid in terms of surgery, and they'll wait it out a little bit longer, and that's perfectly fine. We cater to those people just like people who are, not willing to live with any pain whatsoever, and we'll fix those people sooner than later at times.
All right, let's talk a little bit about the surgical procedure itself. If you can kind of give us an idea of what happens behind the scenes in the operating room.
Yeah. So, I mean, the surgeries, even in the last 4 or 5 years, all surgeons in Nashville would tell you the surgeries has gotten a lot easier on patients. It's amazing, the anesthetic improvements. We do things with regional anesthesia and not as much general anesthetic anymore, which has made the recovery a lot easier for patients. The surgeries have gotten a lot easier in terms of just being able to fine-tune the implants and the techniques. And so overall, it's not the knee and hip replacements that your parents or grandparents may have experienced 10 or 20 years ago. The surgery, people often will have a misconception about what it is to get a replacement. It's not like we're lopping off big pieces of bone and really changing drastically the joint. It's really just removing maybe about 1/4 of an inch of the arthritic surface and replacing it with a metal cap in a knee replacement. It's not cutting off, huge chunks of bone. It's not anything major. It's just kind of shaving off a little bit and putting on some metal caps and resurfacing the worn out joints.
All right. So tell us a little bit about recovery, because surgery has come so far, and for doctors, obviously, it's not as intense as it was years ago. You're able to get a patient in and out quicker. So obviously that might mean a little bit easier recovery for them.
It is typically. In the short period, I mean, I'm doing about 10% of my patients as outpatients these days, which is great, and it's completely patient's choice. If they want to go home the same day, they can. If they want to spend a couple days in the hospital, that's fine too. But it's easier in the sense that patients can get up and get walking an hour or two after surgery. They get therapy right away these days, and the therapist works with them. And a lot of times you can weight bear and walk on your hip and knee replacements right from the get-go. They're secure and solid so that you can do that. And then, patients just kind of progress along at whatever speed they want to through their hospital stay. Most people are going home these days because their mobility is so much better than it used to be. And then, they just, it takes them about 3 or 4 weeks to kind of get over the majority of the surgery. I tell patients it's kind of like, in the first month or two, your bone has to get used to the new implants. And it's kind of like going to the gym. If you go to the gym and work out really hard, you're sore a day or two later.
Sure.
It's the same thing with a knee replacement or a hip replacement. If you do a lot of activity, 2 or 3 weeks after surgery, you're going to be sore the next day. It's not surprising. Most patients, realize that, I overdid it yesterday, and now I'm sore. But it's very doable. There's not any real restrictions. You kind of get through it. And a month or two later, you're getting around well and able to do most of your normal activities.
This is a conversation I know you have to have with your patients, and something that I think makes a lot of people apprehensive about having any kind of procedure in general, but there are risks associated with any kind of procedure. Can you talk as far as joint replacement surgery, what kind of risks somebody might face?
Sure. I think the one that patients and doctors worry probably the most about is infection, which are very rare, usually about 1/4%, so it's extremely infrequent. But that's really one of the ones that kind of people worry about the most. For me, what I worry the most about is falls. Anytime you have a hip or knee replacement, a patient's balance is going to be off for a month or so. It just takes a little while for your body to get used to the implant, and people don't have that recovery. If they slip a little bit, you and I, we would just, stabilize ourselves and we wouldn't fall. But in the early post-operative period, people just don't have that ability to recover from a little slip, and they'll end up falling and hurting themselves. So I caution my patients multiple times, try to take it easy. Don't put yourself in a situation where you might slip, like in the shower or, out on the slippery sidewalks with all the ice we have this week. So just be smart in terms of your footing. And that's what I worry the most about. The other complications we worry about are blood clots, and we put people on blood thinners to prevent that. And with the early recovery and the fast mobility and the blood thinning medicines we use, that's very rare, so it's not a major concern.
All right. As we're winding down our conversation, I'm always curious to know if there's anything people can do to prevent injury from happening. I mean, obviously it depends on, as we age, what's appropriate, but what would you tell people? What kind of advice would you recommend, Dr. Kurtz, when we're working out or when we're, running around with the kids or whatever it might be?
For prevention of arthritis, I think the most important thing is maintaining an appropriate weight and exercising. And if you can pick an exercise that is what we call a closed chain activity, where your foot's staying on a pedal, that's like an exercise bike or elliptical machine or rowing machine, those are ideal because it's low impact, but you can get a good cardio workout. So weight is probably the biggest preventable reason or easiest way to prevent arthritis.
All right. Well, one other thing I'm going to quickly ask, since we have a little bit of time. Partial knee surgery, I know, and full knee surgery, is there a big difference?
Yeah, I mean, the knee is actually three components, three compartments, and you can replace one of those compartments or you can replace all three of those compartments. So partial knee replacements, typically you would say that there's a little faster recovery, a little bit more feel to a partial knee replacement because you still have some of your normal bone to kind of give you some sense and feedback. Total knee replacements is more common by far. It's about 90% of the time, and it's a little bit of a solves all the problems in the knee. So with the partial knee replacement, you do worry that they may develop arthritis down the road. All
right, had to get that in. Thank you so much for your time, Dr. William Kurtz, talking about joint pain today.
Thank you.
Did you know 1 American develops Alzheimer's disease or dementia every 67 seconds? Of Americans aged 65 and older, 1 in 9 has Alzheimer's, and for people aged 85 and over, 1 in 3 will develop the disease. Memory loss diseases are progressing rapidly. In 2050, it's estimated that 1 American will develop a memory loss disease every 33 seconds. Alzheimer's will cost an estimated $1.2 trillion in this country alone if nothing is done to stop the epidemic. To find more information, visit alzheimers.gov.
Visiting with us now is Dr. Andrew Sandler. He is the CEO of Abe's Garden, which is an Alzheimer's and Memory Care Center of Excellence in the Nashville area. And thank you so much for your time, first of all. If you don't mind, Dr. Sandler, tell us about Alzheimer's and dementia, if you can define them, please.
It's amazing how many people I run into who have trouble with those terms. Dementia is a general term that describes somebody who's having difficulty and a loss with their cognitive functioning. But dementia is not a disease. Alzheimer's is a disease. Alzheimer's is the most common cause of dementia. But there are other causes of dementia where there's a cause that somebody can get help with. For example, depression and medications and thyroid problems. So what's really important is that people get help as soon as they're noticing that they're having a problem with their cognitive functioning so that they can address those functionings, those problems.
If you can, Dr. Sandler, talk a little bit about who these diseases usually affect.
As a person gets older, they're more likely to get dementia. In fact, almost half of everybody who has dementia is over the age of 85. You're also more likely to get dementia if an Alzheimer's disease if you have a brother or a parent who has it. So there's definitely a genetic component to it. And of course, cardiovascular disease is the common cause of vascular dementia, which is the second most common cause of dementia.
All right, so we're talking about the elderly population who's primarily affected by this, but the younger generation, when we think of early onset, tell us, Dr. Sandler, who that would be. I mean, at what age they may experience early onset, and what early onset is.
Alzheimer's is not an old person's disease. In fact, 5% of everybody who has Alzheimer's is under the age of 65. But that is just so devastating because of how early in age the person is getting the disease. It's hard on the person, it's also hard on the caregiver. And because of how long that this could go on, there's a bigger genetic component for people who have an early onset.
Let's talk specifics now. When we talk about, risk factors for Alzheimer's and dementia, tell us maybe in your mind if you have a list of what those would be.
Well, people my age often joke and think that they're getting dementia or Alzheimer's because they can't remember something or when they misplace their keys. I think we do it because we're kind of nervous about it.
Yeah.
But actually, that isn't a problem. The risk factors are when things happen more frequently. For example, when memory problems get to the point where you are misplacing things frequently, or when You keep asking the person the same thing over and over again. Other risk factors are changes in mood, changes in your behavior, when you misplace things, when you have trouble finding words. For example, if you can't say the word umbrella, but you describe it as something that keeps the rain off of you.
I see.
Disorientation to time and place. Those are some of the things where if you're seeing those, you probably should see a doctor and try to see what's going on.
A lot of people may not even recognize that they themselves are doing this sometimes. I know that exists in families. So obviously it's important for family members to rally around these folks too, and if they notice it, obviously get this person to the doctor. I mean, when it's repetitive, like you said, and just reiterating this for folks, you know, who are watching the program today, it's a redundancy thing. So if somebody themselves are doing this kind of thing, they don't know to go ahead and reach out. If you notice it in a loved one, should you pick up the phone and call the doctor?
Yes, you should. And the other thing that's important is that if a person gets a diagnosis, it's really important to also tell other people that they're having a problem.
Very important.
Because over time, a support system is just really crucial. So a good dialogue is important, and it's important to learn as much as you can about the disease, because knowledge is power.
Absolutely. We know certain ailments affect women, men, children, you know, maybe different racial backgrounds, but when we're specifically talking gender, do more men have Alzheimer's or more women?
Well, actually, women kind of have a double whammy. Number one, they are almost twice as likely as a man over the age of 65 to have Alzheimer's, but also because women are better caregivers, they're also twice as likely to be the caregiver, and so the person's going to have to take care of somebody with the disease. So it's very difficult. It's very difficult.
You mentioned once somebody is diagnosed with this, the good foundation, the support system is essential. How should somebody prepare who is going to be a caregiver of someone who's been diagnosed with Alzheimer's or dementia? How should they prepare themselves for this task?
Well, again, I said knowledge is power. Learning as much as possible, talking to the doctors so you have a good understanding about the diagnosis and also a good understanding about what the future lies ahead of you is real important. Probably the biggest variable about quality of life for someone who has a diagnosis of Alzheimer's is the caregiver, because this person's going to be they're going to need to be helped by this caregiver all the time. And it's important that the caregiver sees the person as not a disease, but as a person that has a past, they have knowledge, and they have a future. Because somebody who has Alzheimer's may not remember what's going on at the present, but they have very significant memories about emotional events and memories about things that they did a lot of the time throughout their lives. For example, they'll remember songs, they'll remember religious events, they'll remember prayers. These things that they did over and over again, like us riding a bike, never leave them. So it's really important for the person taking care of them to see them that way. The other thing that's important is that the patient is empowered as much as possible to be making decisions about their lives, and that should happen in the very beginning. It's really crucial because before the person maybe loses their ability to talk or make good decisions, so they can make end-of-life decisions.
Sure, very important.
But then as it goes on, as you and I, we all have the right to make choices about things that we want to do every day, the things we enjoy, when we want to eat, what we want to eat, when we want to take a bath. And that's as true in the beginning as it is when someone goes into a residential community. Unfortunately, they don't always have those kinds of choices in a residential community.
Let's talk just briefly, too, we only have about a minute left, about treatment options. Is there treatment for Alzheimer's?
Well, there's certainly lots of medicines given for cognitive problems.
Okay.
Unfortunately, there's too many medications given for behavioral problems, psychotropic medications with bad outcomes. There's so many good interventions and behavioral approaches that you can use to really help somebody live with a dignity and with choice. And the key is knowing that person and realizing that all behavior has meaning and really trying to see what's causing the behavior. I call them, I don't like the term behavior problems. They're not behavior problems. What the behaviors that sometimes people see are symptoms, but they're not the behavior. That's not the problem.
Yeah, and obviously there's so much more to learn about Alzheimer's and dementia, so it's probably a good idea for folks who are going to have to deal with this kind of thing with a loved one. As you said, knowledge is power. Educate yourself, you'd probably say, to make sure that they know everything to expect of what life has in store for them.
Exactly.
All right.
So important.
All right, Dr. Sandler, thank you so much for your time. It was a pleasure visiting with you today.
Thank you. I
Great
really enjoyed it.
information.
Thank you.
Thank you. And thank you all for tuning in today to Community Health Matters.